So what my discussion, however, will be not related to diversions and very different from his. And so I'm going to discuss or go behind the curtain a little bit to discuss the effect of divided expert opinion and the insufficient evidence on consensus panels, whether that's for guideline statements in particular. My experience is specific to male incontinence, but I would propose that it can extend to other guidelines as well. Okay. All right. These are my disclosures, and I'd also like to say that I am not a representative of the AUA guideline committee or for this particular panel for past, present, or future. So in terms of the objectives, again, I wanted to compare the incontinence after prostate treatment guidelines to other non-oncology and so a few selected oncology guidelines in terms of the strength of recommendations and the level of evidence, and look at the areas of discordance on the consensus panel or guidelines as it applies to the male incontinence ones, and look at the reasons for the differences in opinion, and discuss what the effect of the lack of consensus ends up being. So I participated in the ICS SUFU AUS consensus panel, and this was published in the Urology and Urodynamics in 2015. Subsequently, I was on the AUA SUFU guideline for incontinence after prostate treatment. So it's on the basis of my experience with these two panels that really dealt with male incontinence that I wanted to look at the areas in which the opinions differed. Now these are the two separate panels, and there are a few people, including myself, who are on both, but even though there were a larger number of people on the consensus panel for ICS, that the outcome was really somewhat the same. Now, the process for the formation of a consensus panel in this instance and the guideline panels was a little bit different because the consensus panel was much less formalized in a way, and so the selection of the participants was really selected on their experience with the AUS and their publication record. The topics were somewhat agreed upon by the panelists, so a systematic review was not necessarily done first, and that's the reverse when you're talking about a guidelines panel. We then agreed or tried to agree on the majority of statements, and then the level of evidence was then graded based on the Oxford Center EBM. In comparison, when you look at a guideline panel, you have the panel chair, and also they do pick people based on experience, but because the charge of the incontinence after prostate treatment was slightly different in that it was treatment for male incontinence, not just the AUS. There were also some other members that were included: urologic oncologist James Eastham, and a physical therapist Daniel Karagias, and then to represent the public, the patient advocate, and of course also, since you have a true systematic review, you have the methodology expert. And after that, the systematic review is completed, then you proceed with the guideline statements and then rate the evidence, but also the strength of recommendation. So when we're covering gaps of evidence in which there are significant ones, then you come into the area of clinical principles and expert opinions. And those of you who've looked at any of the guidelines may be familiar with the AUA nomenclature for looking at recommendations and strength of evidence. So let's get into it. I first wanted to just see, after my experience, how the AUA, the IPT guidelines may be compared with other randomly selected guidelines. So I looked at some non-oncology and oncology guidelines, just in general number of statements. It's amazing how many statements the lower urinary tract one has. And then looked at the level of evidence. And the fact that the level of evidence on the IPT one was fairly low was not surprising, but it does appear when you look across the board of the ones I selected that that's not that common. They're, except for prostate cancer, the amount of the percentage that's level A evidence is fairly low. I then also wanted to look at the strength of the recommendation to get the idea again of how this compared to the other guidelines. And it's amazing how your perception when you're inside the process can differ significantly from the reality when you look at it objectively at the end. I really would have thought, based on the amount of discussion that we had, that there would be a lot more expert opinion in the IPT guidelines, when really it was fairly low in comparison to some of the other guideline statements. But looking between the ICS panel and the AUA guidelines, still it was clear to me that despite the difference in processes in majority, in general, a different group of people, that the areas of disagreement were really quite similar. And as Colin pointed out, that oftentimes the guidelines are not helpful. And they're often not helpful in areas where you really need them to be, especially if it's an area where you're not as experienced. For example, management of pre-existing overactive bladder. Now, this was an area in which the members of the panel, their extent to which they managed overactive bladder or urodynamically even proven overactivity differed significantly. So the AUS consensus panel in this area says detrusor overactivity should be treated. And again, you get in the differences of the nomenclature between, is it just symptoms or is it urodynamically proven? But regardless, the recommendation was it should be treated. And what does that really mean? Does that mean, and I'll discuss that in a moment, what does that really mean? When you look at the AUA guideline, it says that treatment should be offered, which is a much lighter statement. So it doesn't necessarily imply that you should treat it, but that it's maybe a suggestion to the patient. So in reality, when you're dealing with this situation, probably the AUS consensus panel therapy or suggestion really ends up with you feeling like you need to have some kind of assessment of whether the patient's going to respond to any anticholinergic or antimuscarinic agent, and now beta-3s at all, just for future reference, just to know if they're going to respond and if it's severely bothersome. Because really there's no reason necessarily to interfere with their treatment, and the patient will often resist if you're going to go on a full line of overactive bladder treatment and their incontinence is very severe. And on the flip side, there's some patients where some of this symptomatology reduces after they have some outlet resistance and their bladder kind of recompensates after being decompensated or severely leaking over a long period of time. And then there's the need for trying multiple agents, and how far along the OAB algorithm do you go? When you look at the guidelines, the AUA guidelines, it's probably more realistic in terms of maybe trying the patient on a medication and then discussing third-line options, and we'll deal with this patient group in third-line options on Saturday. Since we mentioned detrusor overactivity, that would imply that you actually did a urodynamic study. And that was another area of discordance between the group. We ranged everywhere from no one doing urodynamics to people doing fluoroscopic urodynamics in every patient. So when you look at the consensus panel, it's again at the discretion of the clinician. And the AUA guidelines, again, urodynamic testing in a patient may be performed, but again, all these are very lukewarm in terms of the level of evidence and the level of the recommendation. The fact is that either extreme is incorrect. Doing urodynamics in no one and doing urodynamics in everyone, but what is the midline? And in the process of making the guideline, it somewhat did mirror the female stress incontinence, and some of their panel members were also on that guideline committee, the recommendation for the non-index patient, so the more complicated female patient also is a may and not a definitive in terms of urodynamic testing. I think we had definitely an agreement that there was, a lack of evidence. So there is some evidence to say that the results of a urodynamic study doesn't necessarily influence the outcome or your decision-making when you're treating male incontinence. But there was definitely very clearly inconsistent application of urodynamic testing among the panel members. And this may also relate to just the situation within the office. For those who have it readily available, there was more of a tendency for those to test more freely rather than those that had to make maybe special arrangements for urodynamics. And we didn't really have a consistent trigger for what would necessitate a definitive need for urodynamics. All radiated patients with symptoms, hydronephrosis. So there was really no clear set of recommendations that we could really put, in the guidelines. Now, this is something that you would think would be very obvious, and there would be no discussion about evaluating the bladder neck before, especially putting in an artificial urinary sphincter, for example. The AUS panel stopped short of saying that you must. There was a high recommendation for preoperative endoscopic evaluation. But we did say in this case endoscopic rather than just some other indirect way of evaluating the bladder neck versus the guideline panel, which again was not 100% definitive. It said should, because this may affect the outcomes of surgery. Well, it's further than that. It may affect whether you can do the surgery at all. So the realities we found is that there was really no disagreement about whether the outlet needed to be evaluated. The question was, what was the mechanism for that and when? Was it trying to pass a catheter in the clinic? Was it actually looking in the outpatient setting? Or was it in the operating room just prior to planned placement of a device? And there was no evidence that looking visually is better than, I think I just lost my, I don't think this mic is actually working, is it? It's dead. Okay, can you hear me? Okay, good. Oh, yes, I know you. Yes, okay, here it's back. There's no evidence that looking is better than just calibrating, but I prefer to look, and I think many people do, because you want to see whether the urethra looks pale or whether it looks healthy and evaluate where you're placing the cuff. But again, there's no evidence to yay or nay. And really, the reasons for not doing the cystoscopic evaluation in the clinic were really more logistical in nature. Is this approved by insurance? Do I have a slot? There's several other people in the clinic. We only have a certain amount of scopes. We only have so many, people assisting us. Is it going to be more comfortable for the patient to wait until the operating room? So really, those really have nothing to do about whether this is something that should be done or is appropriate part of an evaluation before going into the operating room. And then if you're going to do it at the time or in the OR, this does go, it is in contradiction to kind of trying to minimize urethral instrumentation at the time of surgery. So, but the failure to assess the bladder neck prior to operating room can have other effects. If you have poor communication with your staff and they open an accessory kit, which is expensive, prior to you being sure that you can proceed, then who bears that cost? There's also the patient effect. They have to be willing to accept the fact that you don't know for sure exactly which procedure you're doing. There's definitely a difference between ending up with a sphincter and then having a VIU versus a balloon dilation. What about catheterization at all? In the AUS consensus panel, we ended up having no comment, primarily because there was no agreement. It was almost 50-50 between people utilizing and not utilizing catheters. And that may be something that, that would be helpful for someone who doesn't do as many of these devices to know. There was nothing specific in the AUA guideline because it was less focused on individual operative steps. What about evaluating the urethra after you do the dissection? That was clearly discussed in the AUA consensus panel, despite the fact that really not everybody that was there actually does evaluate the urethra after doing their dissection, although it definitely would be highly advised to do so, again, especially in an occasional implanter. And again, this wasn't the type of area that the guideline itself addressed as well. So what about an area, in comparison to the ones I've discussed, an area where there really is maybe some better evidence? There was really no dissent about perioperative antibiotics, although there was some institutional differences and maybe dictated by the antibiotic or infection control committees at individual hospitals, but really there was no any discussion about the administration, the timing, and the choice of antibiotics under ideal circumstances. Where we did have some discussion was around post-procedure antibiotics. And this was an area that I was assigned in terms for the AUS consensus panel. So this was really one of the first times, at least in the US literature, where for a prosthetic, discussing recommendations for a prosthetic device, that antibiotics, post-operative antibiotics were omitted from recommendation, post-procedurally. And there is no evidence to support giving an extended course of antibiotics. However, that being the case, I think the majority of people were, at that point, especially 2015, I think the tide is progressively changing on that, but the majority of people were giving post-procedure antibiotics for AUSs and for IPPs, and I think that's still often the case for IPP. In the discussion, we did discuss some mitigating circumstances, perhaps people who had prior infections, diabetes, other types of immunocompromise, and I myself, after writing the guideline, then I had to follow. So then I had to slowly wean myself off of giving these patients antibiotics. So it's definitely been a process, but I think we're going to have a discussion later about proper utilization of antibiotics in other settings as well. So what about device failure replacement strategy? And this is something that's also discussed in terms of what type, whether it's a mechanical failure or even in cases of atrophy, whether you need to replace the entire device or can you go with replacing a single component if it's potentially identified. And our statement was that whole system replacement was preferred. However, in the tiny print, it discusses removing, if you can identify a specific component, replacing that one. But the whole system replacement really has its roots in two of the other recommendations that I didn't, or two of the other statements I didn't list. The fact that the quick connects are really not guaranteed for old tubing. You really have to have a fresh device for the quick connects to be somewhat guaranteed or for them to stand behind the connection. And then the AUA guideline statement was, little less specific, just really spoke about revision, but this is just like a single device, a single component issue in which I would just replace the balloon. So in summary, the level of evidence for the IPT, when I looked at it in comparison to the ones I randomly selected, was surprisingly to me comparable with the other guidelines. And it was very similar when I looked at the AUS panel guidelines, despite the fact that the processes for forming the committees and the methodology was different. It does seem that low levels of evidence can really influence the recommendation when there isn't enough evidence. Then the preferences of the experts then really come into play. And this can be seen in other guidelines, not just male incontinence. And when these statements include the variations of practice, that they may be less definitive than intended or than would be helpful for other practitioners. And that even when you have substantial evidence, like in antibiotics, sometimes the practice patterns still remain. Thank you.